Good evening, everybody. Thank you all so much for joining us on this cold Melbourne Monday evening. I hope that you're comfy at home and under a blanket and with a heat pack or hot water bottle if you need to be. I'm so excited to introduce the first in our online webinar series, No Endo, Endometriosis and Pelvic Floor Physiotherapy. To start with, I just want to proceed with the acknowledgement of country. So Epworth Healthcare acknowledges the peoples of the Kulin Nations, the traditional custodians of the land upon which we work and care for our patients. We honour the unique and continued spiritual connection that Australian Aboriginal and Torres Strait Islander peoples have to land, waters and culture. Just a couple of housekeeping items before we get into it. So there is a chat box available for you to submit your questions. We do hope to answer your questions throughout the evening, and we'll save these for the end. So if things pop up for you throughout the series, type your questions in, and then at the end we'll address these. You can submit them anonymously, or you can pop your first name in there when typing in your questions, and a recording will be available at the end of the event. We also just want to acknowledge that Epworth is proudly inclusive, and there may be times during the webinar where the term women is used, and this is done in recognition of encompassing non-binary and gender diverse people who were born with female reproductive organs. So as some of you may know, I'm Nikki Campbell. I'm the Endometriosis Nurse Coordinator for the Julia Argyrou Endometriosis Centre at Epworth, and my role is to support people with endometriosis at every step, so through diagnosis, treatment and management at Epworth. And I'm so pleased to have with us tonight Miss Annette Beauchamp, physiotherapist, and she's a physiotherapist who loves to help people achieve their best pelvic health and has extensive practical experience in both hospital and community settings. So Annie, what is pelvic floor dysfunction?
So the term was originally intended for use with difficulty with bowel evacuation, mostly related to an inability to relax the pelvic floor well enough to allow the passage of stools, so have a poo. But really you could apply this term to inability to relax the pelvic floor to pass urine, to complete passing urine without a sense of straining against a closed door, as well as with bowels, and then you could extend it further into the idea of not being able to relax the pelvic floor muscles to allow insertions of tampons or having penetrative sex, whether that's penile, digital or play or objects, or having vaginal or rectal exams. So you can encompass it by saying it's an inability to relax the muscles. So we call muscles that have high tone hypertonia, and this seems to be a common feature. In plain English, you might think of the word as overactive. They're not exactly the same, but it's probably close enough for plain English. Think of it as a spasm that doesn't turn off, really.
Thank you. So how common is pelvic floor dysfunction in endometriosis patients?
Well, in my life, it's very common.
Me too.
I'm sure I could find a bunch of different studies giving a bunch of different names, and you said yourself to me a couple of weeks ago that you found that when you were researching to do your thesis.
Yeah.
So there's a subject from, an article from 2021 that says 30% of women with a deep infiltrative endometriosis have chronic persistent pain. So I'm sure that probably it's more and probably it's less. So there's probably 80% of women have some pain at some time, and probably a lesser number have pain all the time, and probably a lesser number have severe pain some of the time or all of the time. And, you know, numbers are always rubbery, so it really depends on the population chosen to be assessed and who's done the assessing and what they're actually looking for. And pain and hypertonia gets to be a circular thing, and they seem to both be a function of persistent pelvic pain with endometriosis. And this is where physio comes in.
Yeah.
So our aim is to reduce tone in muscles of pelvic floor muscles and the other muscles that attach to the pelvis and the abdomen. So think of the pelvic floor muscles being inside the pelvis and then muscles above and muscles below that attach. But it's multifactorial. There's other stuff as well, and we'll talk about that as we go through the slides.
Yeah, and the reading I'd done, one of the numbers said up to 70% of patients with endometriosis experience pelvic floor muscle spasm. So that's not necessarily like continuous dysfunction, but they're having spasms, you know, perhaps with their period or things. So that, you know, that's a very high number. It's almost like we need to assume it's there unless we can prove that it's not.
Yeah, well, that's the thing. So if a client tells you stuff, you believe them, and then you look for the physical stuff that supports or refutes what they're saying, but you've got to believe them.
That brings us nicely to our next question. How do we know if someone has pelvic floor dysfunction?
They tell us. So they walk through the door saying, I have pain, and it happens when and it might be wee, poo, have sex, use tampons, have an exam. It might be other stuff. It might be just nothing. It might be sitting around. It might be exercise. It might be movement. They might know that their endometriosis is also partly aggravated by their hip pain or their back pain or leg pain or chest pain, even like high abdomen where the diaphragm meets the chest. So there's just that multifactorial thing. But yes, if a client tells me they're in pain, I believe them. And
what would be
most physios do.
Yeah. What would be some red flags, do you think, of things that people tell you?
Definite triggers. So they're going to tell me that there's definitely a pattern with menstrual cycle, bladder, bowel, daytime. So, you know, worse in the morning or worse in the evening or worse related to particular activities. So for me, it's that. Also indicating wear on their tummies. So classically just below the belly button, the navel, I call it para midline. So if you went 3 fingers out from each side of your navel and down probably 3 finger spaces, that's typically where ovaries and uterus refer onto the abdominal wall. But you might also get flank pain if you've got bladder or kidney pain too. So it's usually the lower half of the abdomen is where it all starts. And then it might work its way up and it might work its way back through the pelvic floor. Some people start around the vagina.
Okay. What's the first thing someone with pelvic floor dysfunction should do?
I think it's really important to establish who your health providers might be. Your GP is central to this. So you want to have a good GP that you can have a reasonable discussion with, who communicates well with you and sends you to good people. So they really are the central pin that refers out, and they have the feedback from having treated other clients and having colleagues who've treated other clients. So that's probably the main thing, is setting up your team. And, you know, everyone's team is different. So some people have psychologists, some people don't. Some people have physios, some people don't. Sexologists, etc. The other thing is I'd like everyone to stay as healthy and well as they can despite their endo. So perhaps make or write a plan who can help you with your endo and when, and then write a plan that includes things beyond your endo. And it might be simple stuff like going for a walk or catching up with friends and family, but it's really important to maintain your head well-being and your physical well-being by doing stuff and not get so locked down into endometriosis, because I'm sure it can be like that for some people where it just grabs you and takes over. With regard to your symptoms, try to be logical, write stuff down. So figure out what's it triggered by. So is there a specific thing that you are doing that triggers it, and how quickly does it trigger it? So does it trigger it immediately, or is there a little delay until it comes on, or is there a long delay until it comes on? Does it come out of the blue? You know, like, do you wake up in the night with pain up your vagina or up your bottom or up your urethra? Then think about what type of pain is it, and then you might work out, actually there's several types of pain here. So one's burning and it's related to when I do this, and one's sharp and it's related to when I do that. Or it might be achy. Figure out what the relationships to the pain are. So you might have pain related to your menstrual cycle, but that's also related to your bowel behaviour. So it might be the ache and discomfort of the period coming on, but then you might have constipation beforehand, which gives you one type of pain, and then you might have diarrhea for the first couple of days of your period, which gives you a different type of pain. So it's sort of all menstrual, but it's also almost irritable bowelish. Got to apologise for the reflection on the glasses, people, sorry. Then you might also figure out, actually there's particular foods that I react to that just make it worse. And so there are some things you're going to work out quickly, and there are some things that you're going to have to wait for repetition of that pattern. What are you avoiding is another one. So I'm not doing this because I think it might hurt, you know, so actually do it and see, does it hurt? And if I do it more, does it hurt more, you know, and then go back to not doing it for a while. Stress is a big one. So if you're working, sort of figure out when you're stressed at work, is your pain worse? So, and that's going to be like an aggravator rather than a true trigger, but you want a full idea of how the pain and the other symptoms are going on. So you might also have fatigue, you might have a sense of fullness or tightness as well. So just try and work out stuff, write it down.
Annie, what's standing out to me as you're mentioning all these things is that's very much the responsibility of the person who is seeking help from a physio. Would you describe that process of sort of symptom tracking and becoming self-aware, mind-body connection, those kinds of things? It's almost empowerment, isn't it, to find out those things, and it's not passive at all. Even though it's assessment, you are learning and gaining insights about your symptoms in order to manage them more effectively going forward.
So one of the hugest secrets in health, which should be on billboards, is you are your own health advocate. So people can go into bat for you, write letters for you, send you off to people, but you're the one who's got to figure out what's aggravated, what's improved, who's helpful, who's not. You know, like you wouldn't get a plumber in to fix your toilet 3 times. So if something's not working for you, then you might look at another person in that same field or another allied health person who does something similar, or go back to the drawing board, go back to your GP and say, this really didn't work, what's another option? But you've got to be your own advocate, which means you've got to be responsible for keeping track of what's going on. So I'll usually tell people to use the notes section on their phone, and you can do it all on the one page, or you can make different pages. So you might have one page that's just, you know, left lower abdomen pain, when do I get this one? And you might write down the date that it happened, what you did beforehand, how long it lasted, that sort of thing. Or you might write down what's urinary, what's bowel, what's gynecological, what's related to my physical activity. So you might have several different pages. I don't want copious notes, so I don't want this to become onerous to the person who's making the notes. It's really so that you can establish the pattern of your triggers and your alleviation. So people will come to me and say, I know that, you know, heat helps on this occasion and coolness helps on this occasion. So self-massage of this particular point might help. So be your own advocate.
The more insight you have and the more knowledge you have about your situation, the more tools you can use to manage when you do have flare-ups and to help settle things down. Yeah.
Very good.
So can someone with pelvic floor dysfunction see any physio?
Oh, Okay, so you
this is a hard one.
The answer is no. So you really want to find someone who has experience with persistent pelvic pain. So I would be reading the bios of people in your area. So I'd be looking up someone who does pelvic health or women's health or whatever other similar term that you can think of. And then I'd be putting in pain or endometriosis or bowel or bladder or whatever it is that's affecting you. It might be coccyx pain. And then just read the bio and just see, you know, is this person telling me a bit about what she or he does, right? So I'm in Melbourne, and so most Melbourne pelvic health people are female, the physios. So you're going to be reading the female physio's bio on what she does. You could ring and chat to someone. So, you know, if you ring, you're going to get me. But when I've worked for an organisation, you're going to get the receptionist. So it's just when I ring that person, are they able to answer my questions? That's how I would find a good pelvic physio. Certainly you would assume that someone who's older has more experience, but you can get into pelvic physio at any age. So I'd just be looking at how much experience do they have. But it's, you know, we're back to the plumber story. You might go a number of times and think, yes, I'm with the right person, or I don't think this is quite right for me. That's okay. We all see clients who've seen other physios. I'm sure some of the people that have seen me have gone to other physios as well. I think distance matters. So I have got some country clients who come to the city, and they might have a regular physio at home or a regular other sort of health therapist. So they're not going to be able to afford the time and the money to come down to the city a lot. So I'll include their country person. There's a couple of junior physios around Melbourne who'll refer to me, and I'll want to keep them as part of the program because they can do some of the stuff and it's closer to home and less expensive than coming to see me, because I'm sure I'm in a part of town where the rent's quite high. So yeah, it's about building your team. So I've got a couple of myotherapist massage people that I work with, as well as other physios. I use musculoskeletal physios as well, especially if someone presents with back pain or hip pain.
All right, so will someone with pelvic floor dysfunction need to see a physio regularly or long term?
Yes to both of those. So now everyone gets into different patterns of behaviours with their clients. So my particular pattern would be that I'd see someone for at least an hour on the first occasion and possibly a second and a third. So I want to build up a really good picture of all the things that go to their sum total of their problem. So not just the pain, but all the other symptoms that they're having as well, so that I can then work out a system of how we're going to treat this and in what order. So I'll usually say to people, I'm going to be a very good friend of yours for at least 6 months and possibly up to 2 years. There are times when clients need physio holidays. And so I'll always say to someone, tell me when you hit that point and let me know, and then I'll write myself in my diary a note for contact this person in 2 months or 3 months.
Yeah.
So I always say physio's got to fit into life, not life's got to fit into physio. So you've got to, and because it's therapist heavy, so you might be seeing several therapists at once, you're going to get burnt out if you're seeing 3 or 4 therapists in a month.
Yeah.
Time-wise and dollar-wise. So it's, you know, sometimes I'll just say, okay, stop seeing me for a while, go see the psychologist or the sexologist for a while, or maybe it'll come from the client sometimes as well. Yeah. Eventually I'll break it down to a 45-minute appointment and a 30-minute appointment. And so, like, I've got quite a few women at the moment who are on 30-minute appointments, but I've known them for longer than 12 months, okay? Yeah. And then the interval gets bigger and bigger and bigger and bigger, but I keep the interval flexible. So if I'm going from, say, a 4-week interval to a 6-week interval, I might book someone in at 4 weeks and say, when you get this 4-week appointment and you don't need it, message me and then we'll delay it so that it's now 6 weeks, so that they don't feel stressed that they're hanging out until that 6-week appointment.
Yeah.
But it's all flexible, you know, and people have to have holidays and do all sorts of things.
Including you.
Yeah, me too.
Annie, someone's asking in the chat, how long until results are seen with physio? I just thought that fitted in nicely with what you're talking about.
Sure thing. So I suppose it depends on how you approach the problem. So for me, I want stuff that's self-reliance first up. So I'm going to be teaching you behavioural strategies first, and maybe big stretches first, and self-massage. And then once I think you've got a handle on that, I might get on to more manual tasks. So how long? So I'm extremely happy if we hit the 50% better mark by 3 to 6 months. But what's 50%? So I always say, like, if Nikki, you were coming to see me, I'd say, all right, what's the Nikki score? So do you feel 50% better than you were 3 months ago or 6 months ago? Yeah. And if not, why not? Which is the, you know, symptom that's most bothering you right now. And it might not be what I expect. It might be something that you say that's completely different, like it's my left hip. Oh, right, okay, so we actually need to spend time on your left hip, you know. Yeah. So yes, it's be accountable. So work out for yourself, how quickly am I getting better? But I'd probably say 3 to 6 months. But you know, in your heart of hearts, this person is helping me or this person is not helping.
And when you consider that against other forms of treatment that we have for managing endo and various pains, it's actually a reasonable time frame, because if you were to trial a medication or anything, you need sort of 3 to 6 months to give it a good go. It's a 3-month recovery from a laparoscopy, things like that. So there's no quick fix, unfortunately.
But, you know, even like with each appointment, I'll have given someone a homework. So we'll talk about one of those homeworks in about 1 second. But so with a homework, I'm going to say, okay, so when you left here last time, you were going to concentrate on this thing. What have you learnt? All right, so I know that I do this when I do that, and I get better if I do this, but I don't get better if I leave it for half an hour or whatever. So it's that sort of thing of, you've got a stepwise improvement as well, but I'm after the overall improvement.
All right. Is it? Are we on to the next one? Did I miss one?
This is what I'm talking about.
This is my favourite one. What self-management strategies do you give someone with pelvic floor dysfunction? Okay,
so you know, everyone explains stuff differently. So this is like the Annette Beauchamp branded activity that typically I will give people on day one. So I call it drop the jaw, drop the floor. So we have 3 major diaphragms in our body. So one's at the throat, one's at the true diaphragm, and then the next diaphragm is the pelvic floor. And so there was a study, I don't know, in South Australia for having children, having babies, I think it was back in the 80s, and they looked at, if you close your mouth and push a baby out, the pressures are much higher in the vagina, and that just stuck with me forever. And so then I thought, all right, so if you actually drop the jaw and open your throat, then you're probably reducing the pressure in your pelvic floor. And of course, now we know with all the stuff on relaxation that that's exactly the case. So just relaxing. So drop the jaw, drop the floor means open your mouth and sigh. My lips are relaxed, my tongue is relaxed. Let my belly relax like Winnie the Pooh on the screen there, and that helps my pelvic floor to relax.
I hope everyone's doing this at home. I'm doing it.
So in the beginning, I am ridiculous, and so I will say for the first 3 weeks, I literally want you to do this every 20 minutes when you're awake. So for 3 weeks, and I want it so ingrained that you are almost expecting the 20-minute mark, and also that thing of, you know, let's use work. So you're at work and your colleague says some ridiculous, annoying thing, and you go, and you're squeezing your jaw, and then you're realizing, oh, it's not just my jaw I'm squeezing, it's my pelvic floor and my tummy. Oh, okay. So every time, you know, person A speaks, I need to relax. So that's what I'm after, is at the 3-week mark, people have really got this as a habit, and they come back and they say, guess what? I get tense when I think I need a poo, when I think I need an examination, when, you know, person A at work throws a tantrum or whatever, okay? Then I'll break it down and say, all right, let's go to hourly now, but also when you notice it. So it ends up being more than hourly. And honestly, 6 to 12 months down the track, people tell me that is the one thing that changed their lives, that internal instant relaxation. I'm in charge of relaxing my pelvic floor. I've got to let go.
So good.
All right. I'll turn that into a that same sort of concept. I'll do a nighttime relaxation. So I'll record something that involves breathing and chest expansion and talk to them about how that should happen, and then abdominal relaxation, and then pelvic floor muscle relaxation. And I try to make it in under 15 minutes, and usually it ends up being somewhere between 11 and 13 minutes, just depending on how that person moves, breathes, that sort of thing. And then I'll ask them to do that 3 or 4 nights a week, and that's pretty flexible. So they might do it Monday to Thursday, or they might do it every second night or something like that. But I want it done at least 3 nights a week, and hopefully 4. And that's probably another thing that makes a big difference. So then it really depends on what I have assessed. So we talked about hypertonic muscles, and so those muscles are tight. So tight means that if this is a muscle and it's its normal length, when it's tight, it's shorter. When it's shorter, it's spasmed, which means it expands a bit, and it's using up the blood supply and nutrition for that muscle quite quickly. And if it doesn't relax, it doesn't get increased blood flow into the muscle and further nutrition to the muscle, like magnesium, calcium, all those things that you need. So if they had tight muscles, I'd be giving them techniques for reducing the tightness in that muscle. So self-massage, stretching, trigger point therapy to themselves, that sort of thing. I'll address bladder function and bowel function. And so this is largely about learning what is normal and what's not normal, and then encouraging habits that improve the ability to completely empty when you pass urine and have a bowel motion, and softly and easily, that sort of thing. Intimacy and sex are sort of approached in the same way. So what's missing, what hurts, how do you get around that? So I might have relaxation exercises. I might have self-touch exercises. I might use something called vaginal dilators or trainers. Now, if you'd asked me this 10 years ago, I would have offered you that as number 1. But I use it further down the track now because I want people to use the stuff that they're more mentally and physically together in charge of. But I still will use them quite a lot. I just want to be quite clear on what my purpose is in using them. And then I'll just get them to use other manual techniques in preparation for intimacy. So I'll approach it from a physical perspective because I'm a physiotherapist, but I'll use mental and emotional exercises and give them tips as well. I will include a psychologist and a sexologist if I'm thinking this is now lingering into the territory where physical is outweighed by the mental and emotional loads of past experience, current pain, that sort of thing. Whatever I do, it's completely negotiable and on the client's terms. And I may have a plan for a session, but the client comes in and their symptoms have varied or something new's come along, or they've been to see a specialist who requests a particular thing. So even though I might have a plan, it might change. I use dry needling and TENS machines. So TENS machines, TENS, T-E-N-S, stands for transcutaneous, which means across the skin, electrical, nerve stimulation. So it's applying either pads or needles to an area, and it's a form of physical distraction, but it's also direct to specific nerves that is hopefully going to reduce the local torque between the nerves, between the pain nerves and the spine, but it's also a physical distraction. So I use that quite a lot, and I use dry needling. So often if you're coming through a physio appointment, like the first time you realise that you're going to consider dry needling is when you get the consent forms for dry needling. This is all negotiable because I have clients who come through the door and just say absolutely no dry needling. And then I have clients who say, okay, I'm ready to consider that now, you know, so it varies a lot. Now, I've just realised something that we haven't said. So don't construe anything that I'm saying or that Nikki's asking as relevant advice for you. I cannot advise you strongly enough to go and be assessed physically and get your GP's input. So these are all just ideas, but really it's what's important to you. So I'm saying stretch muscles, but in this person it might be this muscle, and in another person it might be another muscle. So on the screen there you can see the front wall. So in some people I'm releasing rectus abdominis, which is the muscle that's right down the middle. In other people I'm releasing the obliques or the transverse abdominis, and sometimes it's the diaphragm, which is higher up under your ribs. If you turn the person around, which we can't do on here, those muscles go all the way around to the back. So sometimes it's more on the left, more on the right. So it's, yeah, just varies quite a lot. But I just want you to think, don't take this lecture or this chat as self-treatment, please.
Yeah. All right. So what other things can endo patients do to manage their pain?
Okay, so this is my tips and strategies thing. So I'm a fan of distracting yourself. So if you are a person who ruminates, like really sits with your pain, then you can't see other aspects of life and the pain gets bigger. So there's a concept, I haven't written this in the notes for Nikki, so apologies, Nikki. There's a concept called smudging, and we have areas in our brain and they're responsible for the sensation and movement of an area of the body. And I'm making this up, so there might be a spot on your brain here, and it might be the size of, whoops, half my fingertip. And then over time, if I concentrate on that pain, that size might increase. Now remember, I'm just making this up, okay? And then if I have you doing distraction and stuff, that size might shrink down back to, say, whoops, half of a little fingertip, okay? Mm-hmm. Now that's a theory, smudging. But I want you to think I must distract myself, and there's a million ways to distract yourself. So I think there's physical things you can do. So you can spread your toes and fingers. You can tell yourself that the nerves to the toes also supply the pelvis. They do. They come from the spine and go to the same spot. So now that you've made your nerve busy thinking about your toes, it can respond less to your pelvis. So it's that thing of do the physical thing, think about the physical thing. A number of people have IBS, so we'll discuss what things trigger their IBS. So, you know, last week I had someone walk through the door and said, I react to, and they started listing all these different food groups, all these different foods, and it fell quite neatly into the fructans, which is like a group of fructose. Not quite, and apologies to any dietitians listening. So then it became, all right, well, then you need to take fructose out of your diet for a while to let your abdomen and your bowel settle down, and that might take 3 to 6 months. I'll ask them what medications they've trialled in the past, prescribed, over-the-counter, alternative, natural, and figure out what has been helpful and what hasn't. And I might suggest other things. I'm really careful on this. I don't ever want to start a turf war with doctors and other people. So if I think this is a prescribed substance or might interfere with a prescribed substance, I'm going to write back to the doctors involved in their care and say, you know, could we, as a suggestion, trial this substance for 3 months, 6 months, whatever it is, okay? I might suggest stuff that helps people have poos, so probiotics, laxatives, smooth muscle relaxants that you can buy over the counter. Topical anti-inflammatory works for some people, you know, creams over their tummy, and it doesn't work for some people. For bladders, there's substances around at the moment that are being suggested over the counter. So there's Hiprex and D-Manos, and for sex, there's specific lubes. So there's cheap lubes and dear lubes, and the difference is the preservative that's in them. Some of them have been tested for vaginal biome and vaginal pH, and some of them have not. And really, it's just trial and error with all the lubes. Is this going to work for me? Is this not? There's some that I love, but, you know, because of proprietary, I probably shouldn't say it while we're on air tonight. I might send them back to the GP and say, you know, can you trial a specific vaginal or rectal medication? So it works a lot. Then there's the home stuff. So the going for a walk. Now you can see that someone's colouring in a unicorn. I like those colouring in pads for adults because it's a real distraction tool if you're physically disturbed by your pain. It just takes you out, you know, and you're doing something mindless, but you're concentrating on colour and movement in your hand. And it's involving a lot of systems, you know, touch, seeing, movement, colour, all that. And of course, Netflix. Now, Nikki's included a picture. I think it's a warming massage vibrating pad, but
heat pad.
There we go. Oh yeah, you know, if you go to the pet shop, you can buy an 8-hour heat pack.
Yeah.
It's quite firm and it's about just smaller than a dinner plate. Just don't burn yourself. So I have had people from time to time with chronic endometriosis come in, and they've got skin changes where the heat has changed the subcutaneous fat adipose tissue, and now you've got brown streaking on your skin. You need to do something else.
Yeah. All right. So
okay.
Why this is the last of the formal questions. Why might someone not improve or not respond to pelvic floor physio? And then we'll open it up to the floor.
Sure thing. Okay, so this is my we just took this off the net, right? So you would have learnt Venn diagrams in grade 3 and 4 and there would have been 3 intersecting circles where things influence one another. Well, you can think of it like that with endometriosis. And so circle A might be the pelvic floor muscles, and circle B might be the gynecology, and circle C might be urinary, and circle D might be the bowel, and circle E might be the connective tissue that isn't muscular. And there's probably another circle up there, F, that is joints, and there's probably another circle up there that's G, that's the individual nerves that are irritated either by compression or injury. And circle H might be coccydynia. And it's you spend your time sorting out what's the priority today. So some people just do not improve with physio. So some people have something that is called centralisation. So you've spent so much time in pain that it's now occupying a lot of your brain, and that smudging thing has become large. And so now if you go to physio and have your bottom, the outside of your bottom, so the back, I think of it as the hip pocket area. If you've had your backside massaged, you walk out, you're fine. 2 hours later, you're raging abdominal pain. Well, then you might have centralisation. And so this would require a hands-off approach then.
And let alone add, you know, JKLM for biopsychosocial, stress, family,
my mother's
all of those other things. Yeah,
I have to consider IVF. You know, I really hate this job that I'm doing, and so it ends
up a huge web, doesn't it? And having to tease out all the different pieces that are contributing.
Yeah. So I think every now and then it's probably a good idea to take a holiday from all intervention and then just sit down and try and work out, actually, this is useful, this isn't useful. And really the correct interval for, you know, the physio at this point in time is 3 weeks, and the correct interval for the psychologist is weekly, or, you know, it's different at different times.
And it comes back to the priorities as well, isn't it? Like if you've got all those other things going on, it might be that, you know, if it's fertility based, you've got to put fertility at the forefront and leave these things in the background and park them as such until you move through that stage, and then you come back and revisit it.
Yeah. So urgency and importance are competing all the time. Ultimately, most health professionals want you to leave them better than when you arrived. So, you know, if it's not working, you need to communicate with that person who's doing your therapy or your medicine or your nursing and say, it's not working, can we try another way? You know?
Questions from the audience. We have got a lot of questions. Thank you all so much. I've responded directly to a couple of people. It's probably worth mentioning, so someone made a comment back in the beginning about how do we find a reasonable GP. This can be really difficult, and I would probably say that particularly if you're looking for a bulk build GP, it's near on impossible. There are some good ones out there. My suggestion would be to look for somebody who has an interest in women's health and mentions that in their bio, like what Annie said back in the beginning as well when finding a physio. And sometimes people will mention that they've done extended training in women and children's health, or they may have an extra qualification in that. People who have done that and have kind of gone out of their way to take on that additional level of training are more likely to have an interest in women's health, gynecology, obstetrics, and are more likely to be endo-friendly and supportive and understanding of what's going on. But like what Annie said, if it's not working, keep going, because it's not worth sticking with someone who's unsupportive.
Can I add something there?
Yeah, of course.
So in the part of town where I live, I'm on the local Facebook groups, so for my suburb and for my council area, and I reckon at least once a week someone is asking who's a good GP physio in the area. So I think that's a fair way to ask, and you're going to know if you get 25 votes for one person.
I have a small list, but I always like to hear from people that I'm seeing in my clinic, whether they particularly because it's so widespread, whether they've got any recommendations. So feel free to send in your recommendations. Somebody else has asked, is there a symptom tracker app that you recommend? Annie, I don't know what your thoughts on this would be, but I think the first thing that pops to mind is the Quendo app, because they went through such a rigorous process to build the app to include all of the symptomology, and that you can forward that on to your health professionals. It's got your menstrual tracking in there and everything, so check that out. It's free. You need to create a login, but once you're in, it's free. Very useful. I think a lot of the doctors like that one as well. Annie, here's a question. Can you have pain around the vagina and rectum without having endometriosis?
Yeah, of course. So coccydynia means pain in the tailbone, pain in the coccyx. And it puts a strain on the it makes the muscles around that area really tight, and tightness begets tightness. So I call it the ever increasing onion layers. So this muscle's tight, then the next muscle's tight, then the next muscle's tight. So yes, I will see people who have simple muscle pain related to a past injury, you know, like they fractured their coccyx when they were 14 and they're now 28. And they've had pain at various times, and it might be I took up Pilates and it was worse when I did Pilates or something like that. So yes, you can have isolated pain without having endometriosis.
There's another question here actually about coccydynia, which is how to treat it. It's probably outside of the scope of this unless you have a very brief.
Well, it belongs in the physio realm. You want to have someone who can mobilise, which means move the coccyx internally and externally, and you want to have someone who can manually treat the muscles that attach to the coccyx. I'm going like this, trying to see how can I do this with my fingers. If this was the coccyx here and these were the muscles, so you'd be touching those muscles and applying direct massage to those. It's just go see a physio who does pelvic health, really.
Now, there was a question which I really like because this comes up a lot for me in clinic. Is pelvic floor physio always internal?
Okay. Yes and no. So I've got a couple of women at the moment who absolutely cannot tolerate vaginal therapy. So we've started external. Then I've got other women who are much further down the track. So I might have started abdominally or on their back or on their butt cheeks, treating their legs first, and then treating external vulva, and then treating vaginal. But that's in and around all those other things that we talked about. So the TENS, the dry needling, all that sort of stuff. So ultimately, I want it to be internal because that's what the vagina is about, being internal. But the physio should always travel at the pace of the client. Yeah. Does that help?
Yeah, no, that's really good. When would it be suggested to refer to a urogynecologist?
Okay. This will be people who are in pain 24/7 and physio really doesn't help, and you feel like there's a nerve component as well as a hypertonic component. And so, and sometimes I will send people to a urogyne who's already involved in their care. Sometimes I will send them to a pain specialist who specialises in female pelvic pain. Sometimes I might send them to a gynecologist. Sometimes I might send them to a colorectal specialist. Gee, that was a long way of saying that. But it's to me, it's like, what is the spot that I'm not fixing that I think might respond to injections of Botox or local anaesthetic or something like that?
Yeah. Someone's actually asked in here about, it does relate to their personal experience with Botox, but why would Botox sometimes work and why might Botox sometimes not work? And I just think it's probably important for me to mention here that we will have a webinar in September on the use of pelvic floor Botox. So bear that in mind, that we'll be able to go into a lot more detail in that session with one of our gynaes.
Okay, so you might have a hypertonic muscle. The Botox will, oh gosh, I want to choose my words really carefully here because what we speak of medically can frighten you that it's, you know, we're using medical words, but you're thinking of the plain English meanings, right? So Botox is a paralysing agent. And so you use an extremely small amount in and around a nerve, and nerves travel along and with and in and through muscles. So the Botox is to inhibit that muscle from working for a period of time, and it might be 3, 6, 9, 12 months. And you can only put, so can you correct me, Nikki, if I say the incorrect thing, please? So it might be dose related, it might be point related. So they might only be able to do a number of injections in a certain area. there might be several contributors to that pain. Back in the early days, they would overshoot and do too much volume of the medication, and then you'd end up with a nerve or a muscle that was paralysed for too long. But they're way better. Like the people that I see come back and largely are better.
And it could be not specifically related to the site as well. There could be other life stuff happening for the person at that time that mean they don't get the same response towards their pain potentially as well. Yeah. If we're talking biopsychosocially.
Yeah. And we're back to that centralisation versus localisation as well. Yeah. So someone might really believe, yes, this pain is really quite local, it's here, but in fact the pain is here. Now, when I'm saying that, I'm not belittling your pain. I'm not saying that, you know, your pain's in your head. It physically is in your head. So when we have pain, the injury might occur in the periphery, but it's our brain that decides this is pain. But in the case where Botox isn't helping, it might be that the pain has taken over a big part of the brain. Oh, can you say that better than me, please, Nikki?
Yeah, it's the changes in the central nervous system and how you respond to pain, and pain is learned, and the longer you've had that pain for, the better your brain and your body get at responding to that pain. So even when the muscle stimulus is reduced, the pain, the changes in the central nervous system can still generate that pain regardless of the lack of stimulus in the muscle. That can take a while to unlearn and settle that all down.
I hope the person who asked the question feels like they've been answered.
While we're talking about central sensitization, someone has asked, what does hands-off treatment for central sensitization look like? We could talk an hour on this subject alone.
We could. So it's learning to relax. Meditation apps are good. I'm sure if you jumped onto the App Store, you'd find a few. Once again, I'm not sure that we can name stuff.
The Curable. It's free. Everyone can use it. The Curable app.
I like Insight Timer, but that sort of thing. Hands off. So I had someone today who I could not touch their, below the navel really. I know that they are really super tight here when they're tight around the pelvic floor, so I treated there. Made a new recording for them today about relaxation. So it's that sort of stuff. It's the strategies and tips and the keeping moving and doing your stretches.
Yeah. Being able to engage with things despite your symptoms and increasing your ability to self-manage the rest of your life despite pain, and over time it will get easier. Yeah. Oh, we've only got 5 minutes left and there are still quite a lot of questions, so I'm going to try and encompass them. Someone has made a very good observation that a lot of the information you find online refers to, Kegels and underactive pelvic floor and how to re-strengthen your pelvic floor. So they're asking, is there anything specific or any particular exercises or stretches that I shouldn't do?
If you are in pain, do not do pelvic floor exercises unsupervised. That's your number one take-home message. Do general stretching. So stretch muscles in and around your abdomen, pelvis, legs. If you've been in pain for a long time, choose one stretch and do that stretch every day for a couple of weeks to prove to yourself this one doesn't make me worse. Okay. So in the early days, I'm more interested in do not make this person worse rather than I will have them cured within a certain period of time.
Yeah.
So just to add in a stretch, keep moving.
Yeah.
Get assessed.
What does a physio assessment usually involve? There we go. It's another question.
All right, so if you come to me, so I'm sure that other physios will follow something along these lines. So I'll have a long conversation with you about all your systems, so urinary, bowel, gynecological, which means menstrual, obstetric history if you have any, IVF if you've had that, then general health, so other disorders that might impact. So you might have autoimmune disorders, you might have food intolerances as well. Then I'm going to ask you your pain-specific questions. So what we talked about before, what are your triggers? What are your aggravators? What are your eases? Do you have a daily pattern? Do you have a monthly pattern? Then I'm going to physically assess. So because the people that I've seen tend to have had endo for quite a while, there's a wide spread of symptoms usually. So I might assess spinal range of movement, hip range of movement, pelvic girdle tenderness, particular muscle, so local muscle tenderness. I might assess nerve length, nerve irritability. Then I might do vulval testing. So there's something called cotton bud testing, which a lot of physios and gynecologists and urogynecologists do, where they take an ordinary old cotton bud, a Q-tip, and just test various parts of the vulva to try and work out what is super sensitive and why. Then do a vaginal assessment. So in the vaginal assessment, we're touching stuff to see what hurts and how much. So it might be muscles, it might be organs. We might do a rectal exam. Same thing, we're touching stuff to see what hurts. Now, this is not going to all happen on day one. This might be spread over 3 appointments. It might be, I might think I'm not going to do this bit, and then 3 or 4 months down the track, I'll think, all right, so I just need to do that just to make sure that I have refuted that possibility correctly. Or, gee, it might be having an influence, we better assess that. So it's quite a large assessment, but history taking is probably the most important aspect because it directs you as to what you're going to assess.
Yeah. Thanks, Annie. I think we're going to have to leave it there. There's still a few questions, and I'm really sorry for who we didn't get to. I've tried to kind of group together the most common questions. For people who were asking about certificates, if you are a health professional and you were wanting this for CPD hours, can you please email me? My email address is on the next slide, and we can send you something with 1 CPD hour. I also just really wanted to say thanks so much to Annie for such a wonderfully insightful session. I'm sure we could have talked for hours. And for everyone to just tune in and make sure you're signed up to our newsletter so that you can stay across our upcoming webinars. We're looking to have Diagnosing Endo in mid-August, and then as I mentioned, we'll have pelvic floor Botox in September. So once those dates are confirmed and the speakers are locked in, we will email those out via the newsletter so you can register. Thank you so much for sending in your questions. We've had such wonderful engagement. And I just wanted to remind everyone online that if you think that you might suffer from pelvic floor dysfunction, or if you're looking for more support in managing your endometriosis, please contact me using the details on the screen. We can discuss your symptoms. I'm offering free telehealth appointments, and then we can make sure that you've got the access to the best support available around you. And I know that a lot of people online are rural and regional, so we just make sure we're working with our community providers along with our Epworth providers so that you get the best care. Thank you all for joining, and we look forward to seeing you next time. Thanks so much, and thanks, Annie. Good night, everyone.